Thanks, John. I appreciate that. The flattery too, but more importantly, the introduction that does lead up to this particular topic, because I think you're right. It is an evolving field. It's not nearly as interesting as the last talk that we had, but the principles are the same. The success that they have in a mass casualty situation has a lot to do with preparation and anticipation, and this is just another element of that. And what I learned when I went back over this, the paper that John talks about, which is only 3 years old now, is woefully out of date. And it's a field that's moving fast and evolving, and most of it you'll see is evolving because of what we learned, not here, not in the United States, but over in Iraq and now Afghanistan with regard to the impact of mass transfusion. All right. So the obligatory slide, this is actually the first time that I've had to actually have a disclaimer, but factor 7, which we've all been familiar with in some capacity, is actually not approved for use in trauma. And we use it, you use it. I'm sure it's an important component of what's going on in most people's minds when there's a mass transfusion situation. But the company is very clear, and the FDA is pretty clear that it's actually only reserved for treatment of hemophilia and what they call acquired hemophilia. And I'm not really sure what acquired hemophilia is, but I know I've been responsible for it a few times in my life. But the company doesn't approve of its use in trauma, basically, because they don't want to be sued for it. I think the other part about factor 7 to talk about, which isn't as true as it used to be, but I remember it was maybe 2004 or 5 when it just started to be used, but it actually consumed in a 6-month period over 70% of the hospital pharmacy budget. And so we need to be judicious about this medication that's still pretty expensive. That's my disclaimer. Again, John, thanks for inviting me here. I don't think that people realize how important a trauma institution or an institution is to trauma that Wake Forest is in the United States sometimes. Wake Forest has a chair, Dr. Meredith, that's been a driving force in trauma for the country and the world, since we're the leaders in that field, for a long time. You provide the CME for the main trauma conference in the country. And I think the pediatric component of trauma is already there. Wake Forest is the only pediatric designated level 1 trauma center in the state. We just had our site visit, so we hope to be number 2 in the spring when that rolls around. But Wake Forest really is a leader. My interest in massive transfusion came about from the committee that John was talking about in our American Pediatric Surgical Association. We're both on the trauma committee, and there was a seminars in pediatric surgery on trauma that was being developed, and I was asked to review and write a paper about it, which was much easier then than now because there really was nothing there. I'm going to talk about that. I'm going to talk about the cornerstones of trauma management as reference to transfusion, and then to talk about what's evolved with massive transfusion protocols and what goes into a massive transfusion protocol, and then some of the problems that still need to be worked out. You can't show a lot of slides about, the floor in a room after a massive hemorrhage situation. It doesn't translate very well, but this is a good example of the need to be prepared. And we mobilized the massive transfusion protocol for this kid. He was standing on a deck and fell off the deck when the rail broke, and there happened to be a power washer right below. If you've ever used a power washer, they have a little L-shaped arm that you lay the power washer wand on when you're not using it. And he fell precisely and put it directly in the midline of the back top of his head. And that's why he's still alive, because he was smart enough not to be a millimeter this way or a millimeter that way. And so they used the jaws of life, and they cut the rest of the power washer off and brought him in, and then this is what we had to deal with. So we mobilized the massive transfusion protocol, but I think if we'd actually had to use it, we never would have caught up because the sagittal sinus was right there. And the only excitement in this paper was in this case was the group watching me trying to put a central line in this patient who was laying prone, and nobody dared want to move him. But fortunately, he didn't bleed, and we didn't need the protocol. But the point is you have to be prepared. So here's what John was referring to. What I tried to do in 2009, and the paper was published in 2010, was to look into the literature. So now we're talking about literature that expresses what's going on in 2006, 2007 maybe, and try to see what's out there. And there was nothing in the literature except for case reports about pediatric transfusion protocols. There were some papers from the military extrapolated back to the United States that talked about the need for them, but there really wasn't anything in pediatrics, so I took a couple of case reports and we tried to make a suggestion. Fortunately, what's happened since then is people have tried to apply that back to the reality of their own situation. And because of that, there are at least 5 published massive transfusion protocols in children in the literature. And then in a more, a different way, the new Pediatric Trauma Society has, you can publish but removing institutional data. John, is yours one of those 5? I know how your protocols look, and so I was pretty sure that this was one of yours. So again, Wake Forest being a leader in that as well. So, but the point is that all of them are slightly different and have to do with the details of each particular institution. I think the problem that we're talking about that leads to the protocols has to do with the problem of exsanguinating hemorrhage. And if you exclude the patients that die on impact or die instantly, that never make it into the trauma registry because they never make it to a healthcare institution, almost 40% of those patients that die once they're in a healthcare setting are trauma deaths due to exsanguination. And in the military, the way that they addressed it prior to and into the Iraqi war was to use fresh whole blood. And where do they get fresh whole blood? Because we can't really get it. Well, they get it from the other troops. And so that's how they have made success in situations. And it became much more of an issue because in previous campaigns, patients who were going to die from exsanguination died because of the distance from, in the Vietnam and other campaigns, from the time that they were injured until the time that they made it to a MASH unit or to a hospital, that exsanguination. But what was improved in Iraq was the whole transport of injured patients scenario changed completely and became based on helicopter transport. And so a lot of these patients were saved, and now we have the hemorrhage issue, or a lot of these soldiers were saved, and now the hemorrhage issues were different. And so they had success with fresh whole blood transfusions. I think this also goes along with what has become commonplace in all trauma centers to follow what we call damage control resuscitation. And this slide and the next one I talk about a little bit, they're kind of blended together, but basically that says that you shouldn't pump so much fluid into a patient that you bump their pressure up to normal. If normal is 120/80, you probably want to keep them at 90/60 because they're going to make it to the facility. You can stop the bleeding, and you don't basically open the faucet wide open for a patient who's bleeding. So permissive hypotension, a surgical process that is designed just to stop bleeding, take care of life-threatening problems, get the patient to survive to a later day. You've all seen the patients with the open abdomen who've come back from the OR and they're in the ICU and their belly's open and covered, and there's a note somewhere that says there are 12 packs in the abdomen. Basically, open, stop the bleeding, get them back to the ICU, correct their coagulopathy, and correct their acidosis, and warm them up. And that's how you avoid the lethal triad for hemorrhage of hypothermia, acidosis, and coagulopathy. Unfortunately, what we've also learned is that 25% of patients who are massively transfused have some sort of coagulopathy at the beginning of the initiation of transfusion therapy. So we're already behind the 8 ball. And those patients who have that are the ones that are associated with poor outcomes. I'll show that again later in a couple of different ways. And so this has all led to the development of the massive transfusion protocols. The protocols include the standard blood components that we have. We don't have fresh whole blood in our hospital. except in certain situations where we work with the Red Cross ahead of time. But a protocol that combines packed red blood cells, FFP, and platelets has been successful in trying to mimic what the anticoagulopathic factors that are in the blood. So how to develop a ratio that best approximates fresh whole blood has been a major focus of the differences in the protocols and the evolution of the protocols the last few years, and that's why I'm going to talk about that a bit too. Again, some other data: 50% of trauma deaths within 24 hours of admission are associated with uncontrolled hemorrhage. And of those who die in the operating room, 80% of those deaths are associated with uncontrolled hemorrhage. The damage control I talked about a little bit. This is not the time to do a complex repair of a small bowel injury. Staple anything that you need to, stop the bleeding, and get the patient to the ICU. And those that were survivors followed these principles of permissive hypotension, avoiding pumping a lot of crystalloid or non-blood product colloid, and trying to come up with a preemptive, try to stay ahead of the game ratio of packed cells, plasma, and platelets. In order to implement a protocol, first we have to define what massive blood loss is. And again, almost all of these data are going to extrapolate from the adult data because we don't have a lot of data about kids. Different people define massive blood loss in different ways. I think all of us would ascribe to well, you know it when you see it, whether it's on the floor or in a trauma setting. And it's much easier to define it after you're seeing it, and you look back and say, oh, this patient was in that category. And so most people would define it by how much they had to transfuse, how briskly the bleeding was, or what the total volume was in a period of time. So loss of one or more circulating blood volume in 24 hours would qualify, loss of half a blood volume in 3 hours, or ongoing loss of 150 milliliters per hour. And that's almost always measured in terms of chest tube output, because that's our best answer to know in a continuing way of how much bleeding is coming in that situation. Retrospective views often go back and look at the patients who required 10 units or more in 24 hours. And this is not an insignificant group of people. That's as many as 3 to 5% of adult civilian trauma. With kids, it's a little bit different because it's harder to predict which patients are in trouble. We all know that in adults, the ability for an adult to maintain blood pressure and to maintain other homeostatic measures goes kind of like this. But in kids, they're going to maintain, maybe have a little bit of elevated heart rate with bleeding, and then they're going to go. So we know that because kids can be fine with a hemoglobin that's much lower than adults. And that doesn't help us in trying to predict which patients are going to need a massive transfusion, because if we're catching them here, they're already coagulopathic, we're already too late. And so the answer is, just like in the disasters that y'all are going to have a chance to talk about more, is to anticipate what you're going to need before you get there. So every blood bank can deliver packed cells, whether it's O negative or type specific. You're going to be able to deliver the blood products, but the real problem is the coagulopathy, and those 25% of trauma patients that are referred to before who are already coagulopathic at presentation are associated with a threefold increase in mortality versus matched cohort that doesn't have a coagulopathy. In the military, when they reached the forward hospital, and one of my partners, Tim Weiner, just got back from 9 months in Afghanistan, so we talked a lot about this, but they draw labs when they come in, but mainly they're drawing labs just to try to see if they can use type-specific blood instead of the very precious O-negative blood that they have on hand. But they can't use any of the labs to respond to right then and there. Nothing comes back fast enough, and I'll come back to that a little bit later. But all those patients that came in get INRs drawn, and so they're measuring the PT and applying it to standards. And if your INR was elevated at 1.5, which is a significant elevation, those patients were associated with, the soldiers associated with 30% mortality, whereas if everything else was controlled, If they did not have a coagulopathy, their mortality was much lower, 5%. So if you try to take this context and come up with a massive transfusion protocol, it's a lot of different factors that are all retrospective in terms of data. And I think that's part of the problem that different institutions have had as they develop their own massive transfusion protocols, whether it's for adults or kids. But the objective is to develop guidelines for timely and adequate replacement of massive blood loss with appropriate blood components. There's a lot of parts in that need to be defined. What's timely? What's adequate replacement? Do you measure urine output? Do you try to measure coagulation parameters, which are going to be old by the time you get those labs back? And what's appropriate blood components? What's the right ratio? Do we have to mimic whole blood, or are we trying to do something else? The timing seems to be the most important part, because if we don't do it in a timely fashion, then we run into other problems. Hypothermia produces more coagulopathy. We run into calcium problems. We run into potassium problems. We need to decrease the turnaround time for receiving blood components from the blood bank. And if we do that well, then it's turnaround not only there, but also when we stop the massive transfusion, how do we get those blood units back and not waste them, because it's not a easily renewable resource. So the blood bank has to be ready. They have to have an outline in the blood bank for rapid preparation and issuing of blood components. And what we found in our institution is that I could sit there, my partner Kim Erickson, and we could make a very nice protocol based on what's in the literature, what we think, and everything. And the blood bank came in and said, well, we can't do that. We don't work in terms of cc's per kilo. We're not going to send you 13 cc's per kilo now, and then whatever. We have a unit of blood. Do you want it or not? And in the NICU, if there's anybody here from the NICU, which is not a great site for trauma, but they're very much used to splitting units of blood and holding part of it back, and then giving it later, putting the baby's name on it. But they don't really do that in a trauma setting, and they're certainly not going to do that when we're giving them a weight that we're guessing on, or using the Breslow tape or whatever. And so the answer is we need some general guidelines that the blood bank can kick in and follow. And I think that that's part of the big differences. Your institution is similar to ours in that a lot of the resources are combined. In a children's hospital that's freestanding, that doesn't have adult hospital there, is going to be much better able at compartmentalizing based on age or size. But we're with an adult hospital, so we can only fraction out what they're doing for kids in sort of crude ways. And actually that makes sense, because the speed is the issue here, not the accuracy. And the ratio, not the exact precise amount that we're giving at one time, is the key. So we want to make sure that not only are we getting packed cells, but we're getting the plasma, the platelets, and as we'll see, the cryo too. So a better working volume is not replacement of one or more blood volumes in 24 hours, but a little bit of anticipation. If we think we're going to need to trigger a massive transfusion protocol, maybe half a blood volume in 24 hours. Another way to say it was, if they come in and there's already been substantial acute or imminent blood loss, somebody's got their finger on it, but that's not going to be the answer. And also with the addition of likelihood that it'll continue. If you have a peripheral extremity injury and you put a tourniquet on it, that's probably not a massive transfusion protocol trigger. That's a let's replace what we've got, and then hopefully that's going to be controlled. So for us, it's probably anything that defines or anticipates severe blood loss greater than 30 or 40%. Some protocols have built in that the type of trauma itself triggers the protocol. So multiple trauma in the setting of chest trauma and ongoing bleeding in the abdomen will trigger it. Unstable pelvic fractures is a automatic trigger that's occurred in a couple protocols as well. And then if the chest tube's putting out more than 150 a minute, well, that not only triggers a trip to the operating room, but it also triggers the massive transfusion protocol. So as these protocols are developed, the goals seem to be to provide a ratio of plasma to packed cells of 1:1. And I'll go through that and a little bit of how that evolved. And then also to provide them in a timely manner and to simplify the process. That's where we had to work with our own particular blood bank. We don't want to waste blood. We want to provide guidance for the transfusion, but the guidance for the transfusion is really going to be coming from the people who are trying to decide how much we need to give, how far behind are we, the people at the bedside. So the protocols are a lot more about delivery of the units to the patient rather than infusing them to the patient. And a lot of questions come up with this. First of all, who's making the decision? In our institution, it's always a decision of who's activating any part of trauma. Can the nurse in the ER do it? Well, he or she's the one who's there. Shouldn't it be that person? They know. But then somebody else in the blood bank says, well, we did it once and they wasted X number of units of blood. So how do you work that sort of thing out? It has to be done in a way that everybody in an institution agrees. The decision to transfuse is a little bit more clear because it's everybody there together. Almost always these patients are in an OR setting or an ICU setting, and the team's going to be geared up, and there's protocols that direct that. Communication is a big part of this. Somebody's got to be in charge of talking to the blood bank. Somebody in the blood bank's got to be in charge of picking up the phone. So, they know what's going on. That was a problem with us that we were able to sort out. What type and ratio of blood products should be released and what volumes? And who's going to get it there? How is it going to be cooled? We put in a $50,000 refrigerating system in the ER just to solve this problem so that we didn't waste the units of blood, that they were never sitting out for that period of time that now we're going to have to throw it away. And what lab studies are automatically triggered and how can they be useful? And then also directed more at the wastage problem, how do you deactivate the protocol? Because one study talked about just how much blood that they wasted before they instituted the protocols, and to me the take-home message was, wow, I never had any idea that we were wasting that much blood, but we have been, so hopefully we aren't in the future. So fresh whole blood is not really realistic in our system and seems to be available in less than 15% of children's hospitals around the country. How do we combine the life-saving addition of packed cells with component therapy that's going to avoid problems? I'll talk a little bit about the other problems of infection and mortality just from complications of the transfusions. But in general, we have to look at this as this is a primary goal here, and we are trying to complement it with the packed cells with the other components so that we don't have negative outcomes. When I gave this talk last time, I made the box in the right side big enough to look at, and I've actually shrunk it down because this was our first attempt at a protocol that we published. And if you are able to see it carefully, everything is in terms of cc's per kilo. And when we tried to do that, the blood bank said, no, you can't do that. We can't break things up. I'll give you units. I might give you half units, and we'll go from there. And then the platelets don't come in different standard ways that match what you're doing with packed cells, so you have to think about that again. To get to 1:1:1 with platelets, it's not one apheresis unit or one pooled platelet unit, depending on where you are, what time of day, what the Red Cross sent you. So that becomes more complex. But the goal is that that we're trying to deliver a 1:1:1 to most closely approximate fresh whole blood. So there are a little bit of data as we develop those ratios in kids that is directed towards kids. There's one paper last year in the Journal of Pediatrics that confirmed what the adult studies showed, and the kids' studies are so limited that it's worth talking about them specifically. But there are many adult studies that show the same thing, and that is that if you look at the prothrombin time, and if the prothrombin time is normal, then that's associated with a very low mortality. And as the prothrombin time goes up, meaning the coagulopathy is progressively worse, that the mortality also increases. If you turn that around and you try to correlate that with injury severity score and look at gray for not coagulopathic and black for coagulopathic, in low injury severity score who are not coagulopathic, there's no mortality. But at the other end, in patients with a high injury severity score who were not coagulopathic, they had pretty good survival, but poor in those who were coagulopathic. And there weren't any in the worst category that were not coagulopathic. So there's definitely a correlation here, and protocols for massive transfusion need to address that. There's one study in KID that talks about how an increased plasma to packed cell ratio is associated with increased survival. And there are many different adult studies, both civilian and military, that say this. And most of the adult studies conclude that a 1-to-1-to-1 ratio or 3-to-2-to-2 ratio, meaning a little bit more packed cells, perhaps you don't need the plasma, or packed cells themselves have some proteins in them as well. So that a ratio that approximates whole blood is going to give the best survival. Historically, and I don't know if you remember, but when we were transfusing patients in a setting, we were always trying to give 1 unit of plasma for every 3, 4, 5 units of packed cells. And that was what I was taught. And I think that the current data sort of dispel that. And the one way to talk, blood banks and the whole transfusion literature was very opposed to this at the beginning, but what they showed was that you might be giving more plasma or more platelets, but the number of total units that you are administering to the patient decreases, because instead of giving them 18 units of packed cells, you're now only giving them 12 units of packed cells, even though you're giving them more FFP. So, all right, I was going to go over this study pretty quickly because it's not really going to be the focus, but just to keep in the back of your mind why we might have low plasma to packed cell ratios is that there is an increased risk of trauma-associated acute lung injury. And so if you look at the patients that are not in a massive transfusion setting, the panel, they had a panel of transfusion experts in the field of transfusion medicine that weighed in on various topics. And they didn't feel that the evidence was in favor of giving plasma sort of indiscriminately, or with a patient who's not in a massive transfusion setting should be getting plasma at this same ratio. It's only in the trauma setting. And there's pretty good arguments against giving the plasma at a ratio of 1-to-1 just for any patient that needs a transfusion. So once you trigger the massive transfusion levels, which again is hard to define, then it becomes something that makes sense. But the point is that the plasma doesn't come without consequences. You'd rather have an alive patient who's on the vent for a prolonged period of time than a patient that exsanguinated in the OR, though. Data that's relevant to us as well, if you look at burn patients, those patients that received a ratio of packed cells to plasma at 1-to-1 instead of a 1-to-4 ratio, I said this backwards, it should be 4 units of packed cells per 1 unit of plasma, did show decreased AT3 levels and protein C levels, which are good, but did not really affect the PT levels. So maybe if we're just looking at the INR, that we are not really understanding what's going on. But a burn setting is almost like controlled exsanguination. So in a burn setting, there might be more of an opportunity to measure these parameters and make decisions as you go, whereas in a trauma setting, you're always playing catch up. But they did show that institution of a 1-to-1 ratio resulted in decreased packed cells given, and those patients that got more plasma in a 1-to-1 ratio had less metabolic acidosis. And it wasn't significant, but they correlated with decreased length of stay, decreased infectious complications, and decreased organ dysfunction as well. So I think there's data from a lot of different directions that once you have a certain level of bleeding, that you need to change gears and think about a higher ratio of plasma and platelets. And I may be beating the point, but this is really what the evolution of the last 4 or 5 years of these massive transfusion protocols has focused on. What about platelets? Well, I'm not going to get into this in as great a detail, but there are data that show that in adult patients with traumatic brain injury, that there were better outcomes with a higher platelet ratio. And this isn't 1 6-pack of platelets or 1 5-pack of apheresis platelets, but this is trying to correspond when you're giving packed cells that would equilibrate to 1 fresh whole blood. What does that mean? And every different institution's protocol tries to figure out what that means. But there's clear association of a decreased mortality or a higher percent alive of patients who got platelets at a higher ratio than those who got platelets at a lower ratio. There's one paper that's not in support of higher ratios of plasma to packed cells, and Jeff Upperman, who John and I know from being on committees, tried to pool the Southern California hospitals, UCLA and USC, together to make these observations. And the most important part to me is that they were able to look at 6,600 pediatric trauma patients. And of those patients, only 105 were massively transfused. So I think we've instituted our massive transfusion protocol for a child in the trauma setting twice. Now, we've used it in other parts of the hospital. That's the benefit of it for craniofacial surgery and for some of the hemophiliac patients. But there's a very low number of patients that are going to fall into this category. If you also look at another part of this paper, I thought was very interesting because they eliminated the patients who did not survive for 24 hours. And I think that may be an important context for their paper because I think that for those patients who are in the worst hemorrhage category, many of those are going to be in the non-survivors in the first 24 hours, then that might change the data. But what they said is that increased plasma packed cells and platelet, plasma to packed cells and platelet to packed cell ratios was not associated with mortality. And obviously, this study and everything else I've said begs for a randomized control trial. And I'm pretty sure that randomized control trial is never going to happen in kids. But we can continue to observe, and hopefully when we look at these kinds of numbers in institutions or in a city like LA that has employed a transfusion protocol, whatever ratio they decide, we'll be able to look back and compare to the historical and get some value there. There is one study that tries to look at outcomes. At UT Houston, they looked at 75 children, and statistically they tried to match the cohort to children both before and after the initiation of a protocol. And I think they did a pretty good job. They did a pretty good job of matching. If you looked at the numbers of packed cells that they gave, which was how they tried to match them, and then they matched them by injury as well, that they're basically matching by intraoperative packed cells. And if you looked at those patients that got the same number of packed cells, more with the newer protocol got higher levels of FFP, platelets, and crystalloid, and less crystalloid, and those were all statistically significant. There wasn't a significant 30-day mortality improvement, and there was perhaps a trend towards other good factors as well on mortality. And I think that if you looked at after the operating room, the numbers of total blood products wasn't really altered, except that the 24-hour packed cells was slightly higher. So the idea is that if you are giving them in the setting of acute bleeding, and you associate higher plasma and platelet ratios, then perhaps you're going to have an association with improved mortality. Trying to look at specific organ dysfunction, they did have patients that had some increase in respiratory dysfunction, perhaps not enough to be significant, but higher numbers. they talked in their paper that might go along with the association of plasma with increased risk of pneumonia. But this would be a trade-off that we would all take for cardiac dysfunction for longer time on the vent. Currently, I think that there are many more trauma centers who have put in these pediatric massive transfusion protocols, because in the last few years, the American College of Surgeons has gone around trying to promote getting more trauma centers to get a specific pediatric level 1 designation. And as I mentioned earlier, Wake Forest Brenner is the only institution in North Carolina that currently has that designation. And it's the ACS designation. The state of North Carolina that approves trauma centers does not have a pediatric category at all. We've just finished our site visit, and we can't say until we actually have the designation, but I think we'll know something in January, and it was very positive. But I think this is going to help us in a lot of ways, and as you know, when you have the site visit coming, you fix your shop up, and so we were able to put and implement a lot of these types of protocols and take from a paper that we wrote into a protocol that works with the blood bank and works with our ICU. Published papers include a 1-to-1-to-1 ratio from these institutions. John's just saying that in addition to these individual papers that were published, and I threw us there because we weren't quite 1-to-1-to-1, it was like 3-to-2. But the five trauma protocols that are published on the Pediatric Trauma Society website, which is pediatrictraumasociety.org, 3 of them are 1-to-1-to-1, one's 3-to-2-to-1, and that's pretty close to 1-to-1-to-1. And then one study I didn't quite understand, and just the language in it made me think it was an older protocol, but it ranged from 2-to-1 even to 4-to-1 packed cells to platelets. Okay, so take a second to look at our protocol to address some of the issues with delivery and infusion. So how do you account for size differences of patients when blood products only come in one size? So some institutions have talked about doing a weight factor. If they're going to give, the blood bank is going to release 3 units of packed cells, 2 units of plasma, and 1 unit of platelets for a kid who's under 40 kilos, and they're going to do this for more, and then the subsequent ratios are going to come from the blood bank there. One protocol does it by age. But I'm pretty bad about guessing a patient's age coming in, except when it becomes close to the adult, and then I always guess older, so they'll go to the adult side. I don't know about you. At UNC, we kind of did a 1-to-1-to-1/2 because the platelets were considered more precious, and the blood bank wanted us to get measurements after the first round, and we used a weight base based on the Breslow delivery. So if you look at the top 2 charts, for infants, for the first package delivered by the blood bank, it's going to be 2 units of packed cells, 2 units of plasma, and 1 5-pack of apheresis platelets. And the next time it'll be 2 and 2. And then that'll average out to a 1-to-1-to-1 if you do the math by volume. And after the second round, we give 2 units. Now, granted, we don't trigger it, and most places don't either trigger this until they've already gotten 40 per kilo of crystalloid, which is the ACS guidelines or ATLS guidelines. And in older kids, we do the same ratios, but the blood bank, the first package is twice as much. And then I'm going to show the same thing on the next slide. So this is what we just looked at. But when we deliver the units, we are trying to administer them as a whole. We'll hang out of the first pack 1 unit and try to hang those 3 things together. The anesthesiologist or the critical care doc, depending on where we are when it's initiated, is going to try to hang less, and then we give what we think the patient needs, but we always try to maintain the same ratios. And it looks complicated, but it's only complicated because the blood bank has to deliver in these subsets that start with, what do we do for the neonate? And we don't have many neonatal traumas. We did have one, a horrible story that I won't share with you. But the purpose is that this massive transfusion protocol can be used throughout the hospital in any kind of massive transfusion setting. And the blood bank just needed to have one protocol. Monitoring is important, but you can't really do that and make decisions based on it. You just have to assume there's a coagulopathy based on the amount of bleeding. Lab-guided component therapy is impractical, but as far as deciding for the next transfusion delivery, but it might help us to know when to stop. At the same time, we need to be monitoring calcium and blood pH and body temp. Those are things that we can monitor in real time. Our gas, coming, we can get a hemoglobin and calcium, we can get potassium as well, and we can get our pH to know how well we're doing. Just a downside, so complications of transfusion, again, if you're worried about the complications of transfusion, then you probably should be patting yourself on the back because you have a massive transfusion setting and you have a survivor. But we shouldn't forget that there is a increased risk of pneumonia that increases 5% with each unit of packed cells or platelets. And there's an increased risk of infection, which is a similar increase for each unit of plasma that's delivered because of the pooling. But overall, the massive transfusion protocols are going to decrease those numbers of at least packed cells that are delivered. So a bit of a trade-off with the protocols. The problems come with things that I've already alluded to. Reviewing the data is hard. It's difficult for us to get data that doesn't factor in either those patients who died or those patients that we ordered the units and they were delivered, but they passed away, or we stopped the massive transfusion setting before they were actually delivered. And a lot of times the best data for what was transfused comes from the blood bank themselves. And so the data are not always that clear. The military data are particularly focused on the delivery from the blood bank, the release of the blood products rather than actually the transfusion, because it's harder to know exactly what was delivered. And nobody follows their own protocols explicitly, because the protocols are very good for delivering from the blood bank to the setting, but we're going to say, we got a hemoglobin of 15, let's just give more plasma and platelets next time. We've all been in that setting. So these are guidelines. They're not hard and fast rules, and I don't think we should expect everybody to follow them with regard to transfusion. And again, when we're looking in small studies, we need to figure out a way to use a data analysis to get outcomes data across greater institutions, because very few of us are going to be able to put together the massive numbers. Back to that Southern Cal, so out of 6,000 pediatric trauma missions, only 105 qualified as a massive transfusion setting. So that's a good thing, but it's hard to draw data. So before I wind up, I'm going to take a diversion and talk about the other things, and not just packed cells, plasma, and platelets. So what are the other things that are out there? Well, cryoprecipitate and factor 7 seem to have an active place in almost every protocol, and most institutions have that built into the protocol as well. Some places we don't, but some places have a hyperkalemia protocol that's triggered based on the fact that we know that delivery of packed cells, particularly cells that have been in a half-life setting that might be older units and might have a higher potassium, and it's probably a good idea to have a hyperkalemia protocol that goes along with your massive transfusion protocol. There are some compelling data that talk about use of aprotein and blood substitutes in a trauma setting, but they're not currently a part of any pediatric trauma protocol, massive transfusion protocol that's published. So cryo, I always have to look this up because I always forget one of the parts of what's in cryo. So the main ingredient with cryo is fibrinogen, and that's why we're giving it. But it also contains von Willebrand's factor, so it'll correct for that. It also contains factor VIII complex, which hopefully they're going to be getting in other ways as well, and factor 13. But the fibrinogen is the key part. And when we give it, we usually give a dose of cryo that equals about 1 unit per 10 kilos in kids. And the key issues is that might be one thing that you do want to measure at least before you give the second or third round of cryo. And that is that you want, and it shouldn't be a comma there, it should be if the fibrinogen is less than 100, milligrams per deciliter, then that's going to be a situation in which you're deficient and you're going to need to bolster your fibrinogen with cryo. We often make the decision clinically, if we're seeing DIC in front of us, that oozing from raw surfaces, not bleeding from a vessel that we've hopefully packed off and controlled, but just every surface is bleeding. Again, you know it when you see it. In the setting of major head injury, and there's a whole nother literature about traumatic brain injury and coagulopathy. And of course, uncontrolled hemorrhage where you know you're behind. I think a big part of putting cryo into the protocol is that cryo takes 20 minutes to thaw. And we've all been in that situation of where's the cryo? We need it. We're not going to be able to stop this until we get it. And it comes up and it's not thawed. So we got to wait. The consortium of university hospitals, when they polled those hospitals, about 26 of them had massive transfusion protocols, and 36% of those groups of hospitals that had massive transfusion protocols incorporated cryo into that protocol. So I think this is an important part of what we do to correct the fibrinogen and massive blood loss as well. So factor 7, I went to the literature, and then it was confusing because the literature talks about a lot of different types of settings in which factor 7 is useful. The literature from certain hospitals, particularly the hospitals that were British run in the Iraqi war, used factor 7 pretty freely. The company says, and the FDA says, that the use of Novo-7 in trauma patients is investigational only, but may be indicated in situations where conventional hemostasis therapy has failed. The company doesn't even go that far, as I'll show you on the next slide. But it does seem to work. Factor 7, activated factor 7 complex probably works by enhancing the production of thrombin on the surface of activated platelets. So number one, don't give it if you haven't corrected the platelets because it isn't going to work. But we've all seen patients who've had miraculous blood stoppage, bleeding stoppage after giving factor 7. The doses are not well established in pediatric patients. One guideline says 90 mics per kilo. The literature has as wide a range as 35 to 120 mics per kilo, and there are case reports that go down as low as 20, but 90 seems to be a reasonable place to start. I think it's like anything else. We're going to take their weight, and we're going to look at the vial, and we're going to try to decide whether we're going to pay that second vial or third vial as we're opening it, and we're going to try to hit somewhere around 90. If you've given 20 per kilo of packed cells, then you might want to consider the use. And we would also want to consider the use of factor 7 in situations where we're not winning. So we haven't been able to control bleeding with surgery. We have done the correction of hypothermia and the correction of acid-base balance, and that hasn't stopped the bleeding either. And we've been keeping up with the blood products, but the bleeding continues. So that's when we use factor 7, and I think that's what the literature supports. Just like 36% of that group of hospitals have cryo in their protocols, 15% of those protocols include factor 7, even though it's off-label use. If you call the company, and I did this, and they sent me a 33-page document, which I read some of it, but it's very clear that they're providing data, and they tried very hard to prove that factor 7 is indicated in trauma. But currently, their deal with the FDA is that it's not currently indicated outside of congenital hemophilia or factor 7 deficiency or acquired hemophilia, whatever that is. So maybe a bone marrow transplant patient, I don't know. So in company-sponsored study, they've actually tried to sponsor 2 studies. One was a phase 2 multi-center randomized double-blind study, which is great. They showed that it was safe. It seemed to have decreased packed cell use in survivors, but it wasn't enough to do anything except prompt the phase 3 trial. But they did show that there was no increase in thromboembolic events in those patients who had factor 7 delivered. So I think that's important data. They also tried to do a phase 3 trial, but it was discontinued after it was felt to be underpowered. I think what they looked at their data and they planned for 1,500 patients, But when they got a third of the way through and they reevaluated their analysis, they knew that in order to show a significant degree, it was going to have to be repowered to 4,000 or 5,000 patients. And so that trial was stopped. And they did seem to show a trend towards fewer PAC cells in penetrating trauma, but not blunt trauma, in the group that got factor 7 versus the group that didn't get factor 7. I think there are a lot of data from the military, again, that do show in the trauma setting that factor 7 does seem to help stop bleeding. It's difficult to translate that into a 30-day mortality data, but I think that's as good a data as we're probably going to get right now. Two other things that have either been on the horizon or may be on the horizon. Aprotenin is a serine protease inhibitor that inhibits fibrinolysis, and I had to go back and look it up because I've never used it or seen it, and one of the main reasons is that they've taken it off the market. It did help stop bleeding, and it is effective. It helps stop fibrinolysis, and particularly in an operating room setting where you know you're going to have a fair amount of bleeding, like craniofacial surgery or certain types of neurosurgery. And it did show that in cardiac surgery that it stopped and decreased bleeding, but also was associated with increased renal failure in those patients. So that's why it came off the market. In our kids who presumably have better kidney function, they did not see the renal failure. And so there are papers out there, one of them that's been published after it came off the market, from data from before it came off the market, that in craniofacial surgery this is probably something that we should like to continue to look at. I think it's going to be very hard to prove that it doesn't cause renal failure, so we may never see it again. One thing I think we will see and will continue to see is polyheme, or just taking a polymer of hemoglobin molecule that is now an artificial blood substitute, but doesn't have to be refrigerated and has a much longer half-life. There is a potential role for that, particularly in a military setting. The Durham County ER did a trial, which I think is completed now, but the Durham County EMS system, where they carried polyheme on their trucks. And I don't know the outcomes because it hasn't been published yet, but they were able to get enough patients accrued into the study to be able to say something about it, but I haven't seen the paper yet. But the advantages are pretty clear. It can reduce the volume of transfusions of PAC cells needed. It has a relatively long shelf life, and it may be more available and portable for that reason. There was one multi-center randomized controlled trial in adult civilian trauma, which basically was a positive study in that they showed that the groups who got them, even though they were slightly different, were close enough to be reasonable. No kids were involved. And the groups who got PAC cells versus the group that got polyheme had the same 30-day mortality. And this comes from the Moores, who are in Denver and have been able to produce 2 decades of appropriate, approved, and respected literature. So I think this is going to be something that we're going to be hearing more about in the future. So one summary slide, and then I'll stop here for a minute. I think that massive transfusion protocols are here to stay. They're delivered by need. They're delivered by experience with adults, particularly in the military setting. And they're being driven by the American College of Surgeons Pediatric Trauma Designation process, all of which I think are a good thing. The goal is to address the problem of coagulopathy associated with massive bleeding to be able to get control of hemorrhage. And I think they've been effective in reducing morbidity due to coagulopathy, at least in the adult setting so far. And the one study that we have from Houston, I think they've definitely been proven to be effective in reducing the waste of blood products. And the current ratio of 1 unit of PAC cells to 1 unit of plasma to 1 equivalent unit of platelets is probably going to be about where the standard evolves and settles into as more and more papers come out. There's definitely a role for cryo and factor 7 in trauma, but it's not well defined now. And again, the caveat that it's off-label use for factor 7. I really appreciate the opportunity to come. It's not nearly as exciting as a lot of the other talks that are on your agenda, which I think are going to be both compelling and uplifting and interesting as well. But I think this is an important part that we all need to be aware of, and we should all go back and look at the logistics: who to call, how do you do it, how do you trigger it, when to give it, and be familiar when we have that very occasional kid that comes in and needs it. So, thanks. Any questions? In the back?
Yeah, I know you said following the serial labs and things right after you give the transfusion wasn't very beneficial, but I'd like to ask you and Dr. Petty both. Typically, how long do you wait till you finish the transfusion of the products before you get follow-up labs?
So I think our blood, it's not in our protocol, but our blood bank and our ICU docs feel like after the second round of blood products, that's the best time to check and see how we're doing. And that may be more logistic than anything, because when we trigger it, the first round is coming whenever we get it, and we're just giving it as fast as we can get it. And then the second round, when we get that, now we have to make some decisions, because I don't think any protocol gives cryo every single time. And so for us, the decision after the second round, that our fibrinogen is going to be perhaps have some value to us. But we usually draw labs when they come in, and then after the second round, or as we're starting the second round, we'll get another set. But it looks much nicer in a chart than in reality, and usually we are guessing on the plasma. We're trying to just not think and give packed cells in plasma in a 1-to-1 ratio, and then platelets. If we start to catch up, then we might say, well, maybe we don't need to be given so many platelets. Like I said, fortunately, we haven't had to use this in trauma very frequently, but we have used the protocols in a couple of settings for major tumor resections and with craniofacial combined neurosurgery craniofacial cases that can tend to be pretty bloody. So the answer is easy after the second round, but in practice, it's let's see how else we got. John, you had your hand up. Can you answer his question too first? Yeah.
I don't know. I mean, other than sometimes you're at the bedside and you can't not be giving something. You know, you see blood coming out of the back or the chest tube, and so the labs are history, right? You're treating what was the case when they were sent, and so. But sometimes you can't just sort of wait on anything because the patient's still. I think they are, like Dr. Evans said, really helpful for how do you wind down. You know, when is the time to put the brakes on a little bit, or oh yeah, we really are kind of behind on where we were with platelets. But I would agree that it's just a lot of kind of in real time. It doesn't feel like you're sort of in the old checklist, but you're kind of working your way through and doing what you do.
Any other questions?
Have any of your studies looked at it from a pre-hospital setting where we don't have the option of a massive transfusion and we're purely doing crystalloid and our only option is to drop faster?
Well, I suspect you'd like to reach for a bag of polyheme to give in those settings. I know a lot of EMS units carry blood with the O-negative blood in the helicopter, but there aren't studies that have looked at that in terms of the components. There are studies that have looked at transfusion of packed cells, and those are part of the data that the people who are in favor of the blood substitutes are saying that we need to do this, we need to do it. As soon as we put the IV in, we can identify those patients who are in a massive transfusion need right then and there at the scene. So why shouldn't we be triggering it right then? But I don't know of any institution or any paper that is carrying the component therapy or carrying fresh whole blood. So you're limited to just the packed cells. But it would be nice to be able to compare pre-hospital lab draw, are you ever getting that, with when they get to the hospital after they've had 3 units or something like that, packed cells. But yes, it needs to happen, when you start. John?
Just a real practical, but two questions really. What's changed, since you've had the protocol sort of in your own sort of experiences before and after? And then the second is kind of who drives it? How is the blood bank sort of on the telephone all the time, or is it a bedside person that's sort of conveying information? Is there a
So, as far as what changes have happened, we don't badmouth the blood bank as much anymore. They're not these random people that need to like get off their rear ends and get down here. And so, just working with them to develop the protocol and to develop communication lines that supersede everything else that's going on. We need a direct line to the blood bank. We need to talk to them. That's helped. I also think in the way we do it, when we respond, pediatric ICU responds, and the adult trauma team, depending on time of day or whatever, also may respond. And so the consistent across the board who's going to stay with the patient is the pediatric trauma fellow, the pediatric ICU fellow or attending who's there. And it's sort of like in the OR, I don't want to be telling the anesthesia what to give. I want to be focusing on the bleeding. So in a massive transfusion, massive hemorrhage setting, we've tried to designate the PICU person as the one who pays attention to all that. And then they're supposed to designate somebody else to be the communicator to the blood bank. And in 2 cases, that seems to have worked pretty well. And I don't know, it seems like everybody in the hospital responds to a pediatric red trauma. And so instead of having an adult team that's used to dealing with it, now we have 3 times the number of people down there. And so having organization in the chaos helps. And we've improved that a little bit by having more protocols, but it's still an issue.
That was actually similar to the question I was asked. Our hospital just recently switched to an all online, all ordering system, and so my question is about communication and how you would recommend expediting that process. Whether there needs to be direct calls made and written orders, how that would.
I'm very worried about that. Our epic go live date is April. Here's another off-label discussion coming. So, and our system has decided to have one system that has to be agreed on between 3 different hospitals. And the blood bank, I sat in all these meetings. How I got on that committee, I don't know. But it's a major problem because they don't think, Epic doesn't think in pediatric terms whatsoever. And so we've tried to develop protocols, and I think that doing it in units or half units may help. But if you try to talk cc's per kilo to Epic, it just doesn't work. So that's we're very worried about that. And there's a little bit of built-in time left where we're going to review things and try to fix it. But I don't have good answer to your problem because it's my problem. So, all right. Any other questions? Well, thanks for your attention.